Thank you, Kitsari, for the kind introduction. Uh, it's great to be here. I never expected a meeting in this grand scale. Well done to the President and the Council for putting up this great show here. And the best part is I'm enjoying Anuradhapura because caught up with some friends who were lost for the last couple of years. And the best part is I'm seeing some medical students whom I have taught about 10 to 15 years ago who are doing really well in their career. They're very proud to be part of your journey. Thank you. Okay, the task today for us is, thank you to my good friend Anuradha Jayathilaka. Very quick telephone call. This is the topic. You get 20 minutes and 10 minutes for the discussion, and that's it. Here I am, Anuradha. Okay. Considering the mixed nature of the audience, I took the liberty to modify my topic slightly. A patient with acute abdomen, assessment and decision making at the primary care level. Now, who is a primary care doctor? If you look for the definition, that's the doctor who is the first contact in this context. So when you get a patient, any of you can be the primary care doctor here. You may be a doctor working in a regional hospital, you may be the OPD doctor, you may be the ETU doctor, or you may be a specialist in another unit. Maybe a physician, maybe an ENT surgeon. So you are the primary care doctor in this context. Now, the definition is simple. It's sudden onset acute abdominal pain. Depending on what you read and whom you are listening to, there can be subtle variations. Some people think it's a surgical disease. Not necessarily. And some think the pain has to be less than 24 hours. Not necessarily again. Acute on chronic, the best example I can give you is acute on chronic pancreatitis. Now, do they need immediate surgery? No. We'll discuss this later. Now, it's a challenging condition to diagnose for many reasons, because usually it's a combination of multiple symptoms and signs. If you are lucky, you might get a patient with a straightforward acute abdomen, like a ureteric colic. But most of the situations, it's not. Elderly patient with multiple comorbidities, coming with bowel obstruction or perforation, and failing organs, so you don't know what to do. Therefore, I'm suggesting that you have a systematic and organized approach in the assessment. Now, remember, the goal here is not to make a diagnosis, but to dispatch this patient to the correct place. The right patient to the right services within the right time frame. This is the theme today. The challenges are due to many reasons, as I said. Abdominal cavity extends all the way up to the fifth rib superiorly. And inferiorly, it ends in the perineum, where GI and GU tracts end. Don't forget, some of the intra-abdominal organs are retroperitoneal. Pancreas, kidneys, ascending and descending colon. So your patient might come with subtle symptoms. The type of pain can be any of these. Visceral pain is originating in the diseased organ. It's a diffuse pain, difficult to localize. Parietal pain is when the parietal peritoneum is involved in advanced cases, or when the abdominal wall is involved. Usually a sharp pain can localize. And it can be even referred pain. The best examples I can give you is inferior myocardial infarction or a lower lobe pneumonia coming with acute abdominal pain. Now, this is a famous MCQ, in my days at least, non-surgical causes of acute abdominal pain. As I can remember, diabetic ketoacidosis, acute porphyria, uremia, then Addisonian crisis, and hypercalcemia. Don't ask me how they get the pain, I don't know. Now, remember, the goal here again at the primary care setting is the right patient to the right services within the right time frame. The journey of a good patient outcome always starts with the history. I'm not going into details. Then the examination. A smart doctor walking into the examination room will look for clues for the diagnosis. Large amount of bilious vomiting can indicate intestinal obstruction. Fever chart with fever spikes on the wall can indicate infectious etiology or infective complication of your patient. Urinary catheter or urinary bag filled with hematuria and clots can indicate stone disease, or it may be a renal tract trauma. Inspection and palpation go in order, don't miss anything. There are no shortcuts. Now, guarding of the abdominal examination is a voluntary contraction of abdominal muscles to avoid discomfort created by you, caused by you. Whereas rigidity is an involuntary contraction of muscles, usually due to underlying inflammation. And if you notice percussion tenderness and rebound tenderness, that indicates peritonitis. Free air or free fluid on examination, you are dealing with a sick patient here. Now, who says surgeons don't use the stethoscope? We love it. Now, very rarely we use this actually to check the bowel sounds. We usually borrow from the intern or the anesthetist. Now, bowel sounds are rumbling or gurgling noises created by the smooth muscle contraction of the bowel walls. Now, increased bowel sounds can indicate bowel obstruction. What happens is the muscles contract forcefully and frequently to overcome the obstruction. Tinkling bowel sounds. Now, tinkling is when the bowels are distended with gas and obstruction, it gives this tinkling sound. The best way to explain this is when it's raining heavily on a tin roof, you get this tinkling sound. Decreased bowel sounds may be advanced stage of bowel obstruction. After the initial stage of forceful contraction, the muscles tend to fail. And if the bowel sounds are absent, you may be dealing with a paralytic ileus or maybe dead bowel. You may be too late. If you hear a bruit in a patient with acute abdominal pain, that's significant. You may be dealing with a leaking aortic aneurysm. Now, there are few signs I think any doctor should know in common pathologies at least. In appendicitis, the rousing sign is when you palpate the left iliac fossa, the patient feels the pain in the right iliac fossa where the appendix is. And Dunphy's sign in appendicitis is you get the patient to cough, they feel the pain in the right iliac fossa. Schwartz sign and obturator sign, depending on where the appendix is located, retroperitoneal or pelvic, you might elicit these signs. A patient develops a severe pain when you are moving the right hip, posteriorly in Schwartz sign, flexed and externally rotated in obturator sign. This is rare hemorrhagic pancreatitis. You might see these ecchymosis in the lumbar area or in the periumbilical region. This is Gray Turner's sign, and the periumbilical ecchymosis is Cullen's sign. Now, do you have to do a rectal examination? Not very useful in this setting, unless you really want to look for melena or fresh blood, or in a case of trauma, high-riding prostate. Whereas a vaginal examination in a young patient coming with acute abdomen can be very useful. The cervical motion tenderness may be an indication of a leaking ectopic pregnancy or a twisted ovarian cyst. Have a look quickly at the external genitalia in a male. Absent testis, presenting with acute abdomen. It may be a torsion of the testis in the ectopic location. Rare, but keep these things in mind. Now, investigation and management at the primary care level. It's difficult because it all depends on what you have. Don't expect everything in base hospital or Patane. But there are certain things that you can do. So even a full blood count, CRP, blood urea electrolyte, if you have facilities, can be very helpful for the tertiary care doctors. So do whatever you can. X-ray, if available, fantastic. At the management, again, there's very little you can do if you are in a smaller center. But if you think the patient needs a surgery and a transfer to a tertiary care unit, the best thing you can do is please keep them nil by mouth. And if you are suspecting an infection, start a broad spectrum antibiotic. If the patient is obstructed, place an NG tube and decompress. That can, you can avoid an episode of aspiration. If you have facilities to insert a catheter, then get some IV fluids and hydrate the patient. This can be really helpful for this patient. Please pick the phone and inform the receiving surgical unit if that's the practice here. Now, you have taken a good history, done the examination, now what? From here, it's a difficult decision now. Need surgery, or can I manage this patient at my level as a primary care physician? If this patient needs a surgery, is he fit? So these are the questions to answer. Remember again, the right patient to the right services within the right time frame is the goal. Okay, this is getting boring. I'm going to have my own quiz now. Everyone was asking questions. Okay. I'll give you 20 seconds to read this. I don't need the answer. The question I have is, will you transfer this patient to a surgical unit or not? Fit young farmer, Nochiagama, acute severe abdominal pain for 4 hours, treated with diclofenac sodium for 2 weeks for musculoskeletal pain, tachycardic, distended abdomen, and impaired liver dullness indicating pneumoperitoneum. And assuming Nochiagama has X-rays, this is the chest X-ray, and there's air under the diaphragm. And the diagnosis here is perforated peptic ulcer. Now my question is, will you transfer this patient immediately? Now, we'll come back to this later. Second patient, again a young patient, presenting at 2 o'clock in the morning to Horopatana with a classical ureteric colic. Everyone carries a smartphone nowadays. Now this is the picture he shows you. Now what are you going to do? Will you transfer this patient immediately at 2 o'clock in the morning to Anuradhapura? This is a difficult one. Third patient, 88 years old, under the care of physicians for cardiac and respiratory issues. Abdominal pain, 3 days. And the history is suggestive of advanced bowel obstruction. And patient is severely comorbid. Ischemic heart disease, severe COPD, on dual antiplatelet therapy. Febrile tachycardic, and on examination, severe tenderness in the abdomen with peritonitis. And you run white cell count, shows neutrophil leukocytosis, and CRP is very high. And this is the X-ray showing large bowel obstruction. Now, will you think of surgery for this patient as the physician or the treating consultant? That's the question. We'll come back to this again. Now, what you do from here depends on many other factors. There's a long list, but I have taken a few here. Now, suspected pathology. You can treat a ureteric colic at your level, but perforated viscous should go to a surgical unit immediately. And a stable patient, walking, vital stable, probably you can observe a little bit more. But unstable patient with low GCS and systems are failing needs prompt attention. Not to discriminate the age, but we all know when we get older, our reserves are going down. And a 98-year-old Attama with perforated viscous is not going to do well, whatever you do. Number of comorbidities and how well they are managed will influence the outcome of your patient. Now think about this patient, liver cirrhosis, child pussy, coming with perforated bowel. Would you like to operate or offer surgery for this patient? He's not going to do well because as soon as you make the incision, there will be leaking of ascitic fluid through that. The wound is not going to heal. And it's going to get infected. And he will have coagulopathy. And eventually he will go into liver failure and hepatorenal failure. The outcome is not going to be good. So think about the comorbidities. Then the functional status of your patient, again, that indicates overall health, and this directly has a correlation of the outcome. Totally dependent patient for daily, almost everything. Following a CVA, almost 1 year on the bed, and totally dependent on bowel, urine, and for feeding. They are not going to do well. So take these into consideration when you make the decision to operate on these patients. Now, this is the highlight here, the calculated surgical risk. Some maths for a change for doctors. Now, surgical risk can be calculated using tools which you can find online very easily. Why do we have to do this? Because when you feed all the data about your patient to these surgical calculators, it will produce a figure indicating the mortality and the possible mortality. For example, 90% mortality for this condition if you perform a bowel resection. So these are two such calculators. NELA score comes from UK, National Emergency Laparoscopy Audit Score, and the other one is American College of Surgeons National Surgical Quality Index program. Now, what is the advantage of calculating the risk for your patient? Because you are talking with numbers now. You tell the patient, look here, if we operate for this condition on you, there is a 65% chance of you dying on the table. And there's 100% chance you will not be the same after the operation. And you will be totally dependent. There's a good chance you will have a blood clot in the heart or in your lung, or you will have a pneumonia, or you will have an infective complication. So it's really easy for you to have that conversation when you calculate the surgical risk. And of course, you have to take into consideration the expectations of the patient and the family. Because nowadays, we talk about personalized care for our patients, and it's really important that you draw a plan for each and every individual patient, because they are not unique by any means. I'm stressing this again, the correct patient disposition is the goal. Now, I can see in the audience, there are some question marks, unhappy faces. Now, am I telling the wrong doctors to do all these calculations? No, all we have done here is we have taken a good history, we have examined the patient, but unlike other days, we thought about a couple of more minutes. to see what is best for our patient. We have done anything fancy surgically here. Any of the doctors or medical students in this audience can do this exercise. Now, after this assessment, your patient will fall into one of these categories. Now, non-specific abdominal pain, you can treat. You don't have to refer this patient to a surgeon. And please review early to make sure that the patient is doing well. Then the second category is a condition that you can manage at your level. The best example is a urethral colic at Horopatana. You treat them, patient will pass the stone in next hour. Who knows? You don't have to transfer them immediately. Then you can do a non-urgent referral later. Need surgical management urgently, good predicted outcome, please send them to us. Need surgical management urgently, bad predicted outcome. For example, the cirrhotic patient we discussed with likely bad outcome, have a discussion with the patient and the family. Be honest and tell them, look, it's not going to be good, but we can try, but we can't promise. And please discuss with the surgical team as well and make sure that they agree for the transfer or the decision before you offer them the final management. And the last category is unlikely to survive. 90-year-old patient coming with severe abdominal pain and your clinical assessment is ruptured aortic aneurysm and blood pressure is 60 systolic and pale and clammy. No, don't even think about a surgery. He's going to die whatever you do. So don't try to transfer these patients at 2 o'clock in the night. Going back to our first patient, now with this new knowledge, what are you going to do for this patient at DH not Chiagama? Perforated viscous. Transfer? Yes, please transfer urgently because he has a good outcome. He can have a good surgical outcome. This patient, urethral colic, DH Horopatana at 2 o'clock in the morning? No. Give them a diclofenac suppository, maybe some antispasmodics. He will pass the stone as we discussed, and we can refer them non-urgently. And this poor lady, 88-year-old, under the care of physician with severe comorbidities with advanced bowel obstruction, impending perforation. Now, what I have done here is I have used this surgical risk calculation for you to give you what is the risk of operating this lady. Now, 88 years old, albumin 23, then the blood pressure, serum urea concentration, white cell count, then the past medical history. And once you hit calculate, almost 70% mortality. So if you didn't know this, you do a heroic surgery at 4 o'clock in the morning. After that, now what? We don't have an ICU. We have to transfer this patient to somewhere and start looking for ICU. And patient will die before you send the patient to ICU at Hambantota. So that's the advantage of knowing what the risk for your patient. Any doctor can calculate this. I'm not avoiding your referrals, but as the treating physician, you are the primary care doctor and you know about this patient very well. And this patient was under your care for 2 months now. And it's easy for you to make that discussion and make the decision. Of course, we are there to help. Now, any doctor or medical student in this audience falls into one of these categories. I'm, of course, in the center, in the surgical unit, but doctor in a peripheral unit, emergency department doctor, OPD doctor, or any other doctors working in other specialties now. Can you treat a patient with urethral colic in any of these circles? I think yes. If it's not working, of course, you can send it to us. Now, can you deal with that patient with child poo cirrhosis coming with bowel perforation at Horopatana? Can you be brave enough to take that decision? I think yes. Because you are educated and you know what you're doing. You have your examination findings and you have your diagnosis and you know how to run the surgical risk calculation. And you can, by doing this, you can avoid a lot of unnecessary things. Early personalized plan, avoid unnecessary admissions, unnecessary transfers, unnecessary healthcare costs. And family and the patient are confused now if you transfer them because they are expecting a surgery once they reach Anuradhapura. But you can avoid all these if you can have this discussion. In summary, acute abdomen assessment at the primary care level can be challenging. And the goal of assessment is always the correct disposition of the patient. And primary care physician has a huge role to play. Of course, we surgeons are there to back up. Thank you very much.